Hi, everyone, and welcome to ABC's of Anesthesia. And this is going out as a podcast and on the YouTube channel. And today, what we're going to do is actually have a chat with Dr. Max Feinstein. This is going to be just a chat all about consent and anesthesia, consent, all the, pitfalls and traps that you might fall into. And it's really great to have Max with us. He's a fourth-year anesthesiology resident, which in Australian terms is a fourth-year registrar at the Mount Sinai Hospital in New York in the US. And relevant to this talk, he also did study some bioethics, so I can't wait to kind of pick apart that stuff. So we got to know each other mainly because he runs a YouTube channel by the same name, Max Feinstein. I'll put a link up here on the YouTube channel, but otherwise you can just search Max Feinstein MD. And that's really designed to give medical students an idea of what anesthesiologists do and what the training process is like. Now, this is what I really love outside of work. Max enjoys playing the drums and in a band of anesthesiologists called Emergence Delirium. So tentatively called. Why not? That's a great name. That's it's the name of a beer as well, a very strong beer, I think.
I think it is. There are some other excellent candidate names. One that comes to mind is 5 a.m. Vasospasm. So this is a band of anesthesiologists who all trained at the same center, and 5 a.m. Vasospasm really speaks to us. There are some other names as well, but those are the top two contenders. So,
look, do you want us to go to a vote with the audience? Just for
It's a great idea. I think I'll put that as a poll on my YouTube channel, and we'll see. So next time we talk, I'll be able to let you know definitively what the band name is, assuming it gets ratified by the lead singer and everyone.
I can't wait to see this. Hey, so Max, we're going to be talking about anesthesia consent, and again, consent is just one of those things that we do day in, day out. It's part of the bread and butter of going into, practice of anesthesia and inducing patients and making sure that, they're actually having something that they want to have and they know what's about to happen. And I always think it's really relevant. One of the great things is you're in the US, and I know the US is far more litigious than Australia is. So, in this discussion, I wonder if some things will come out about how important, consent is for you versus in Australia. If there's any kind of financial issues or difficulties about it. But essentially, we'll probably go through a bit of a framework of, what is consent, and then really just kind of teasing out things in scenarios. And these are the tricky scenarios that a lot of us face in real life, but also in my exams. So hopefully great if you're doing your exams, or just if you have some tricky case at work, to have some way of discussing this stuff. So yeah, Max, just to start with, what is consent? Like what is valid consent? How do you think about that?
Yeah, I like to zoom out really to the highest level possible when I'm thinking about consent. I think it's really easy. I'll just say it's really easy for me as a trainee in the United States to sort of focus on a Western framework of what consent means. And so I think by default, when people answer that question, or at least people around me answer that question, it tends to have the framework of autonomy baked in, and the sorts of elements around that. But I like to start a little bit further out and just recognize that, depending on where you're practicing and what the local customs and cultures are, that, consent may vary. And so I anticipate that you and I will probably be speaking about consent in ways that are so mutually understood and familiar to one another. But it's also easy for me to imagine that, someone who's watching this video, what we're talking about might not be how consent is practiced somewhere else. So having said that, yeah.
Oh yeah, I was just thinking, yeah, I mean, I know in the Western world, we really come from a place where the individual is at the top, whereas I know, what do they call it? The ethic of autonomy, or the ethic of divinity, or the ethic of community. So, in some places, the establishment is the highest point of where priority should lie. Others, it's, potentially religion or spirituality is where your absolute priority should lie. But I think in Western culture, we always think about just the importance of the individual, and just to put it out there, that's an assumption that, I've always grown up with, and I think you have as well, but it really isn't pervasive necessarily in the rest of the world.
Exactly. So in addition to what you mentioned, where and here in New York, where I practice, there's a really large Hasidic Jewish population that I think illustrates the example that you just provided about a community that tends to incorporate more of a religious component as well, where patients, I don't want to jump too far ahead, but it's not unusual for patients to be consulting with their rabbis before proceeding with a medical decision. But the other sort of framework that I think about is a family-oriented framework where families are making decisions on behalf of their relatives, a parent, sibling.
Yeah, absolutely. Okay, so I know in Australia we have this kind of framework of it, it has to, you mentioned autonomy, so it has to be given freely without coercion. You've got to be able to withdraw consent if required. They've got to have capacity, to be able to make a decision, potentially, of a certain age, and they have to be informed. Is that pretty much the same as in the US? Like you have these kind of
exactly. Yeah, that's the textbook teaching here. So, if you enroll in Bioethics 101, basically anywhere in the US, that's the nature of what you're going to hear.
Yeah, okay. So why don't we actually get into a bit of this? I mean, because I think what we ideally have and what actually happens, there's always a bit of a gap to bridge here. What do you say for your standard consent for a patient just having a general play? Let's say, you or I say, let's say 30 or 40-year-old male having an inguinal hernia repair, fit and well, no allergies, no risk factors at all. What do you say?
Yeah. So at the moment, I bake in my consent with explaining what the process of the anesthetic looks like as well. So as I'm walking through, and I always make very clear that I'm describing what the patient can expect from start to finish. And so at the very beginning of the process, an IV is going to be placed. And I mentioned that anytime a needle goes through skin, there's always a risk of bleeding. There's always a risk of infection. And then I describe going on to general anesthesia, and I explain what general anesthesia means. You're not going to be aware of anything. You're not going to feel anything. You won't make any memories. And then as part of that, I say it's very common for people who are receiving general anesthesia to need support breathing. And so this is where I'm simultaneously trying to let the patient know what they can expect, but then also give them the informed part of the informed consent. And so over the years, admittedly, a short period of time that I've been doing anesthesiology, this is our first year of residency, includes very little anesthesiology. So, I'm on my fourth year of residency right now. So, I have gone back and forth between how much detail I provide in the consent process. And I started by saying, we will place an endotracheal, in the event that we'll place an endotracheal tube. And I say, we are going to intubate you. I have shied away from describing it like that, unless the patient, specifically asks. Then, of course, I'll be happy to share that. But what I have gravitated towards is describing that we will provide breathing support using a soft, flexible tube that goes in your mouth, and that's typically how I describe it. Mm-hmm. Going into the consent component of it, as far as risks are concerned, that's where I always mention there's always a very small possibility that I might accidentally cause damage to your teeth or to your lips as I'm placing that device, and that there's also a reasonable chance that you'll have a sore throat for a day or two after the surgery. And then I let patients know, and you described a 40-year-old male who's coming in for an inguinal hernia repair. In this case, I would say your likelihood of feeling nauseous or vomiting afterwards is relatively low. However, it's still a possibility. And so unless there are any reasons not to, I'll give you several different anti-nausea medications. I will say, just in anticipation of what you may ask, for a surgery like this, I typically am not providing or not providing information specifically about some of the more serious but really rare occurrences, rare in the context of this particular case that you're describing. Mm-hmm. I probably wouldn't describe the possibility of death. I probably would not consent the patient explicitly for blood transfusion if it were necessary. Mm-hmm. Having said that, at least at my institution, nurses, the circulating nurse always does consent the patient for a blood transfusion. So I understand that gets done as well. I see that happen around the time that I'm having that discussion. And that's basically where I leave it. I tend not to talk about the risk of reintubation or going to the ICU and the kind of patient that you've described. Just adding emphasis for the context, because of course these are things that I would discuss if it seemed more applicable.
So you don't mention serious stuff as a rule for the low risk patient. And I remember one of my supervisors back when I was training said, "Yep, I don't mention death because it won't change what they're going to do anyway. And if I do, it might just scare them." So that's I'm not going to do. But I think my approach is I say the common stuff. So very similar to you: nausea, vomiting, pain. A little bit of pain is common. Severe pain is uncommon. And you might have a sore throat. And I always try to frame it in a positive light that everything will be available to you in recovery afterwards if you so need it. Don't be afraid to ask. Dental damage, I remember. I think this was from the US, where the largest number of closed claims that occurred were from dental damage. So I think I have to mention that, but luckily I can always follow it up and say, in 15 years of doing this, I've never damaged teeth once, so all good. And then finally, I think I am different now. I will always say life-threatening things, but then I'll anchor it back to, yet it's still safer than driving a car on the roads. Only because you wouldn't have heard of this case, but it was from New South Wales. But Rogers versus Whitaker is this case of this patient who went for an ophthalmic operation. She had one good eye, and they operated on the other eye, but she developed sympathetic ophthalmia. Have you heard of any case like that? Anyway, it was
no.
So the ophthalmologist failed, I believe, to disclose that you can get blindness in that eye if you operate on this eye. And she definitely did the operation. It was absolutely, he was working within the standard ophthalmologist, yet that thing of the chance, even very, very small, of totally being blind to, both eyes, was so significant to her, and he didn't bring it up. And that's what this case was about. So it was material to the patient, and therefore it should have been brought up. And the settlement was huge. It's like, something like $800,000 or something quite remarkable. And because of that, I think, well, death is always material, but luckily I can anchor it to something like driving a car on the roads. The risk in Australia, I think, is about 1 in 10,000 every year of a death on the road. So coming to anesthesia, knowing that, I think in the last triennium, we had some risk of around 1 in 70,000 of mortality under anesthesia. It's safer than driving a car. Therefore, I can always frame it and anchor it in that light. But do you have any kind of perception of having to mention the serious stuff, even in low risk cases?
I think it's a very reasonable thing to do, so long as it's done thoughtfully, like the way that you just did it. The anecdote that you gave about how someone who you work with had pointed out that it can be really scary for patients. I think there's a lot to that. And, baked into the anesthesia consent is the fact that at least in my practice, and I'm curious to hear about yours, but in the large majority of cases, we don't meet the patient until 20 or 30 minutes before we're anesthetizing them. And they're already, they probably already have their sympathetic tone, they're anxious. And so then to say, I'm Max, nice to meet you. I could cause damage to your teeth. Also, you might die. It's a tough thing unless it's packaged in the way that you did. And one other way that a friend of mine who graduated recently, someone who is an excellent clinician, we had a conversation similar to this. And he said, the way that I frame the more serious risk is I say, I couch it by saying, the people upstairs, admin, just want to make sure that I mention that there's always a possibility of death with anesthesia, but not something that I expect. And he just sort of makes it sound like, I have to mention it, but I'm not worried about it. And I actually really like that, and played around with incorporating that in my practice. It didn't quite feel right for me, but I like the approach to that. And so to answer your question, I do think absolutely there's a place for disclosing the really rare but really serious consequence or risks of anesthesia, so long as it's done tastefully, I think. But let me turn the question around for you. What do you make of someone like myself the situation I just described, where for this 40-year-old for an inguinal hernia repair, that I wouldn't mention that. I think I got a sense based on the case report that you mentioned about material harm to a patient, but I'm just curious.
Yeah, I think that there's so many serious risks, and death is, one of the lower ones, but, if I'm using a muscle relaxant, say Sucks or rocuronium, 1 in 5,000 of anaphylaxis, that's pretty material. Less than 5% death with that reaction means that the death is very unlikely, but you can get severe morbidity from that, or awareness. And, there's many other ways you can have harm under anesthesia, but I try to put it all together because I think, like you mentioned, I don't need, if it's, again, overall lower risk, and they would drive a car every year, then they already accept that level of risk. So I can put it all together in serious, life-threatening as a phrase. So that really helps me to cover everything. But also following up with, would you like me to elaborate? Would you like me to elaborate in any more detail? Because I really want them to be able to say, actually, I'm that person that I want to know absolutely everything. And I'll go, okay, great. Here's a list of everything I know that could go wrong, because you're an autonomous individual. I don't want to be paternalistic on this. And I can definitely give you all the information. I can probably refer you to a website with 1,000 different risks, and you can have a read of that while we do other stuff. So I think that's completely reasonable, because in some things, I know, maybe not in medicine, but because I know anesthesia and surgery, but maybe in other aspects of life, I actually do want to know all the risks of something or whatever I'm doing. If you're buying a house or, even a car with special things, you want to know all the detail, and I'd rather the person be knowledgeable about it. So yeah, I think if someone, I would say that for everyone. Well, that's right. The other rule of thumb that I use, and again, this is not for everyone, but I would not do something if I wouldn't have it done to myself. If I was in your position, what would I have done? And it might come to the point of, again, this is totally debatable, but sometimes we do regional anesthesia, right, for certain procedures. If I wasn't going to have if I wasn't going to have a sciatic nerve block myself for a toe amputation, I'm not going to offer that to my patients. It's just overkill from my point of view. So I'm trying to make sure that I'm practicing the way I want my family member to be treated. And I think that's a pretty good rule of thumb. Yeah.
Agreed. One of my mentors in residency very early on had a big impact on the way that I make decisions that ultimately led me to arrive at the same place that you just described, which was I was generating an anesthetic plan for a straightforward case with general anesthesia. And I said, we can maintain this patient either on Tiva, or we can so that's total IV anesthesia with propofol, or we can maintain using, sevoflurane. And I specifically said, it doesn't really matter what we do. And he looked at me and he said, well, what would you want done? And I was like, oh, well, I mean, I guess I would want Tiva, right? I don't know. The wake up seems smoother. It seems like there's maybe a little less emergence delirium. I would want Tiva. And that really changed my practice.
Yeah.
And so now I approach things much more in the way that you just described, where when I'm coming up with a plan of what to offer, or the plan that I'll do without offering, it's not like I will offer the choice.
I'm going to throw this question at you. So Tiva definitely has, it feels like there's a momentum that many people in my hospitals are using Tiva. It's like maybe 5 years ago, none of the trainees were using Tiva. Now every trainee says, they've drawn up the 50 mils and has a range of them in a row ready to go. And so I totally accept that. I think it's very safe. It's very good. Less nausea, vomiting. Generally, people wake up probably feeling a bit better, and obviously less nauseous than with volatile. How about in the case, if you have a gynae case, arms tucked in, and you've got the drip not visible, but the drip is fine.
Not visible, you said.
Yeah, it's tucked in, so definitely not visible.
Yeah.
Would you then choose Tiva or not? And there's no nausea vomiting benefit. Like the patient hasn't said, I really care about nausea and vomiting. And let's not, for the argument's sake, say that there's a cancer surgery as well. And that's debatable, no great evidence for that, but definitely people believe that it will protect against future cancer. What would you do for that, for yourself or your loved one?
Yeah, it would depend on the nature of the case. If this was a case that there was a higher than minimal likelihood of bleeding, we're talking about myomectomy, something like that, right? I'm going to want to have a second IV. And so then I also but more for concern about transfusing products if I needed to. But then I also wouldn't worry about, I'm assuming the concern that you're implying is, I'm doing TIVA and then I lose my IV, right?
Yes.
Yeah.
And you don't know it. And the patient has
and I don't know.
It's a 1 in 1,000 risk, say, or you can pick a number. But to me, that risk in someone who doesn't have a strong indication for it means that I'm probably not going to be that 1 in 10,000, 1 in 1,000 person who's aware, but drips tissue all the time. So I wouldn't do that for myself. But again, that's just me.
If I may also ask, do I have a bispectral index monitor?
Yep, but that's got problems because your patient is, it's not great evidence that it will work, and it will work with a time delay. But let's say
Sure.
you've totally got a BIS monitor as well.
Yeah.
I still wouldn't personally want that.
You wouldn't want TIVA.
I wouldn't want TIVA under those circumstances with the arms tucked in, not visible, and without nausea, vomiting as a benefit that I really need, or say you believe that they prevented cancer recurrence or had some benefit for cancer. Yeah. I wouldn't. That's probably against what most people feel in my hospital.
Yeah, I probably would still opt for TIVA.
Yeah, okay,
and hope that, if my IV infiltrated and, let's say the BIS monitor has its limitations as well. I would just hope that whoever's there recognizes that, maybe getting a little tachycardic, a little hypertensive, and they turn on the gas and then figure it out.
Yeah. And then it's laparoscopic surgery. Therefore, they're already tachycardic and hypertensive. Anyway, sure. Let's end it at that. I'm just making it
there was, going back to the consent question, I think there is one, it's more mundane sounding detail, but I think actually may be a pretty operative difference in the way that we practice, or there may be no difference. In many institutions in the United States, there are not written informed consents for anesthesia. And so the nature of our conversation is not something that has been documented, say, for what I indicate in the medical record that I've spoken about. And by and large, I'm not sure what medical record system you use, but the one that I use, which is called Epic, has checkboxes where we can say it's very easy for me to select that we talked about blood transfusion, ICU admission, and all of the other things. But there's no documentation that the patient has signed like there would be for a surgical consent. Mm-hmm. So I guess my question for you is, do you have written consents that, is it common for you to encounter in Australia, written consent?
Not common, not at all. One hospital did have a written consent at the bottom of the anesthetic assessment form, and a patient does sign that. Many, as I remember, some people just skip that anyway, but the practice in all the other hospitals I've been at is you just write what you talked about without a signature. And we've got like a professional body, ANSCA, Australian New Zealand College of Anaesthetists. They put out these professional guidelines, and one of them is on consent. And it does go through a bit of a detail talking about various aspects in maybe Australian law, saying maybe a written, I'm pretty sure it says something like this, don't quote me on this, but maybe a written consent form may provide extra benefit, but not saying it does. Tick box forms are not necessarily better than a conversation. And often that the documentation is just that a conversation has happened. And if something does go wrong, it's actually for afterwards to be argued about, regardless of the nature of a written consent form. So really a whole lot of, we don't really know. And you just, if you don't want to be sued, make sure your patient likes you and you don't do something, stupid. That's kind of what it feels like it is. Mm.
If I may push an argument from a different side and see what you think about this. Let's say, we're having this conversation about consent and all of the different things that should be included in the anesthesia informed consent. What if I had a different tack and I said, you know what, I think this whole conversation doesn't make any sense, because if you have a patient who a month ago saw their general surgeon and agreed to have surgery, then in agreeing to have surgery, the patient knew that they were going to get anesthetized. They might not know any of the details. They might not know whether it's general anesthesia or some form of sedation. But, when you consent to surgery, you are implying that you also consent to anesthesia and everything that comes along with that. So it's silly to even have a conversation about the risks and benefits of anesthesia. What would you make of that?
I don't want to assume that people know what it means. And I know, the time you might spend in a surgeon's office could be a minute and a very quick discussion. Go, yep, you got a hernia. See you later. We'll do it for you. And I know that they're not talking. I think the consent discussion is a lot about what are your values. Do you sometimes little things come out of. Remember one patient had a foot repair or something like that, and they had really severe nausea. And potentially, if I used opioids, it was going to happen. And my discussion was less about whether they're going to have the surgery, but what do you value more? At a certain point, I will give you lots of pain meds, analgesics, and antiemetics. And what do you value most? Would you prefer? We don't have a miracle magic bullet medications. You will have to be able to decide and negotiate with yourself. Do you want nausea or do you want pain? And this person was like, yeah, that's fine. That was honest. That's straight. I will, choose autonomously what I want to do. But I like that discussion. In one sense, the discussion then becomes, is consent ever valid? Will they ever have all the information necessary to really make a truly informed decision in that time frame that we talk to them? And the answer is probably not. But I know I'm a very practical person, I think. And we're like, you know what? We can have ethical discussions about all this stuff. But again, I think the audience, and if I was learning anesthesia, I just want to know, what do most people do and what's acceptable, regardless of the absolute finessed ethics of whether consent is even possible. So I think, when you go to ethics classes and it's always some random, dilemma, and there's just no right or wrong answer. And a lot of discussion. Yeah, it feels like one of those situations. Would you steal a loaf of bread to feed your starving family?
Right. Yeah, exactly.
The answer is probably yes.
Yeah. It wouldn't be an ethics class without that. The classic one is, would you pull the lever to move the train? Yeah, right. The train's going to kill one person, but if you pull the train's going to kill 5 people, but if you pull the lever, it's going to go somewhere else and kill one person. Do you pull the lever and effectively kill them?
It's a very interesting thought experiment. If everyone hasn't heard of it, it's the trolley problem. Just literally Google the trolley problem, and it's got just multiple dimensions on it. And interestingly, reading about it, you can change the trolley problem to suit the culture of the person. So instead of having trolleys and trains, you can have a river with a boat and a steer and crocodiles or something like that. But the ethics of people in general do still follow the same track. And then anyway, that's quite interesting.
Nice pun.
Wow. Let's get back to consent there. So if a patient was truly highly at risk of dying for whatever reason, imagine that ruptured AAA that comes in, they've lost most of their blood, hypotensive, tachycardic, and may truly die at the end of your syringe. How do you get through consent at that point? Is that more difficult, easier even?
I would say it's probably all other things being equal, is probably about the same level of difficulty to get through. Which is to say, I've done it enough at this point. Had conversations with sick patients who are going in for emergency surgery, where I've gotten comfortable saying, you are at high risk of serious complications from the surgery. And then that I do use the line that you had mentioned, which is, I will tell you more detail about what specifically those risks are if you would like to know what those risks are. Yeah. And I think people self-identify as the ones who you describe, who want to know all of the details, want to know what it would look like in the case of hemorrhage or a cardiac arrest or what have you, and what we would offer. And other people who are much happier not knowing any of the details. And I would say, in this example that you gave of the situation that would, is a ruptured AAA, where, of course, that's going to be part of the disclosure. But I would say that, while the 40-year-old who is having a hernia repair, I'm not going to indicate that this is a high-risk procedure. If anyone is at, basically any elevated risk, then I will have a lower threshold for bringing that into the consent
Actually,
conversation.
I think in that scenario, I've almost made it easier in the sense that an emergency procedure, you're going to have to go through, you're going to die without it. So it's almost like, well, of course you're going to have this anesthetic, and that's probably easier. I'm imagining the elective knee replacement. All they've got is pain, but they can live with pain, or they have, the chance of a very good outcome, except that they've got a terrible heart, terrible lungs, and their preop mortality is in the realms of 10, 30, 40, 50% or something. That's a much harder discussion. And, I think, anyway, that's just a really difficult framework, which I think you've really got to have a long conversation about what someone's values are and what makes them happy, and whether they're willing to, if they're completely miserable at home with their bad knee versus if they're actually just happy sitting on a chair and watching some TV. Would you go through the extra risk? And that's just going to be a difficult decision either way.
Yeah.
I mean, because of, you're from the USA, do you find people are more worried about litigation with your consent process? Is that ever a thing that's happened in your training, or not really?
If it is something that my attendings are more worried about, they haven't made me aware of that.
Yeah.
While I absolutely agree with your characterization of the fact that, the culture where I am is very litigious. I don't feel that at work, and it's possible that that's just a function of me being a resident, and not practicing on my own license, practicing on my attendings licenses. So we'll circle back to that perhaps in a couple of years, and then I'll perhaps have a different perspective on it. But I just haven't felt any sort of downward pressure from my attendings to basically practice defensive medicine. The loud and clear signal that I've gotten from my attendings basically throughout my training has been practice safe medicine. And also, practice medicine ethically, make sure that you're doing the sorts of things that we're talking about, making sure that patients are informed and that you're taking care of them in ways that are appropriate. But I just haven't gotten a lot of sort of hidden curriculum, if I may, hidden curriculum components about defensive medicine.
Yeah, good to know. Okay, let's move on to this. This comes up time and time again. Anytime I think about this poor laboring woman and needing an epidural, and often 4 centimeters dilated, they're in excruciating pain every few minutes. And a lot of the time they just seem zonked out of nitrous or just the exhaustion of it all. And I'm there sticking this massive needle in someone's back. Again, incredibly safe. Day in, day out, we'll do this and have very minimal issues. What do you think about consent in that situation? Actually, let's change up, because we kind of talked about consent under duress anyway. How about the patient just tells you, I don't want to hear it, just stick the needle in? What do you do then?
Yeah. So I actually persist. And so this is tough, because I do feel like there's a sort of duality of autonomy, because on the one hand, the patient is clearly stating, I do not want to hear any more information. But, maybe it's just because the sort of ethic of the way that medicine is practiced in the United States is so drilled into me. I feel like there are certain things that must be disclosed. But if the patient really doesn't want to hear anything, I'll maybe highlight a couple of points from what the risks entail, and that's it. But it's a pretty uncomfortable. I mean, that's obviously very uncomfortable for the patient, no doubt. I'll make it really clear that the patient is the one who's uncomfortable. But then, the consent process becomes a little uncomfortable for me. What would you do in that situation? What do you do in that situation?
Yeah, I mean, we've actually got a consent document that outlines that specific scenario. So I'm actually just going to, this is one of the scenarios I run by my trainees about to sit their final exam, as you are actually. And, you enter a room, begin your discussion of consent. Patient refuses consent. Just put the damn thing in, they say, and what do you do? And so our document says, it kind of talks about consent being voluntary, capacity information, they have information. But they talk about basic information should be provided even if the patient requests no information. And where the patient clearly does not wish for further information and states this wish, that fact should be documented and no information forced on the patient. So that's, that's pretty good. The fact that we've got a College of Anaesthetists guideline saying that, hey, they're telling you that therefore it's fine. I think it's reasonable. I think you can easily get across basic stuff like, serious things are unlikely, which is true. And, you can talk about the common stuff later. So I think it doesn't matter materially. I think epidural is a unique case where many women will have it. It's such a standard of care. So I think that's easy to say in that situation. But I would have trouble if someone said, I don't want to hear anything, and the actual event or the actual anesthetic was highly likely to cause harm. I would have to seek help for that. And I think always in the very uncommon situations, being able to escalate up and just go, medical director or director of my department, or even the legal team, hey, this patient's high risk. I've never encountered this. This potentially is a legal issue, and they don't want any information about consent. I think when you feel uncomfortable after your years of experience, that's probably a good feeling to hear and note, and then seek help, because I wouldn't be able to just go ahead in a high risk situation.
Yeah. If I may relay a brief story, basically a situation that I found myself in, in a sense was along these lines. I had spent some time doing a rotation at a hospital in Colombia, in South America, not Columbia University, but in a hospital in South America. And there was an elderly patient who we had just diagnosed with cancer, but we did not disclose the diagnosis to the patient because one of their children didn't want the diagnosis disclosed. And I had never encountered that before. I hadn't even started my third year of medical school. So I hadn't seen, much clinical medicine at all, but it was just incredibly uncomfortable for me. And I approached the attending and I said, hey, this seems wrong to me. And they were like, oh no, it's like, this is what the family wants. So I found myself in the situation where you're describing, where, you consult your superior, you call for help. The help that I called was not giving the answer that I wanted to hear. Maybe it was the right answer for the patient and their situation. But it really stuck with me. I ended up writing there's a journal called the Hastings Center Report, which has a really great case discussion format that presents a scenario and then has an author argue one side and then another author argue another side. So I ended up making an argument for one side clearly, and asked one of my friends who was also a medical student at the time, but he's Colombian, to argue the other side of it as well. And so, we ended up having a really interesting, lively conversation about it.
We won the argument
in the literature. I'll send you a link, and if you have an opportunity to read it, you can decide.
I will read. So I think I find that really confusing, probably as well. And you just can't imagine what another culture is like, and you really have to try and put yourself in those shoes. But I sometimes wonder how some cultures, forgetting where this is, but just the society moves through a certain level of ethical boundaries or whatever it is. And I wonder if you asked that son, hey, when you're older, would you want your family to make that decision even though you're totally competent? And if the answer to that question is, oh no, I would want to know, then it feels paternalistic and probably a little bit different to what it is, but versus this is the culture that everyone expects at every stage, that I know that when I'm a 20-year-old or a 30-year-old, I will allow my family to make decisions for me because that's what I want as well. Because that's, they're from a culture where every other decision they make for themselves. Anyway, not a bioethicist, just putting things out there.
Yeah, no, it's a really interesting thought. And the one, and not to be annoying about
please do.
Pushing, but people's opinions, people's desires and values change over time. So maybe while that child couldn't imagine having that for himself at that point, maybe 30 years later he would.
And then is it as simple as, hey, Dad, do you want to know? Because we're already implying autonomy of the individual, anyway, that's interesting to think about. Let's do you have much experience with patients, who are Jehovah's Witnesses And there's obviously variable refusal of blood products. And again, this could be ranging to just blood products or FFP or cryoprecipitate or platelets or anything else, even like albumin potentially. And so there's a massive range of things. What's your experience, and have you had any really tricky situations where the surgery is high risk of bleeding and the patient also, let's take an elective laminectomy, multi-level, high risk of blood loss. We don't have to chuck in a von Willebrands or a hemophilia as well, but that would be interesting. But imagine not a great situation and the patient said, look, I'm refusing all blood products. What do we do? How do you feel about that, and how do you frame it?
So we actually, at my institution, we have a sheet that we can print off very easily that has every imaginable blood product or derivative of blood product or something that's synthetic that we can print off, and I mean it's basically a consent sheet but specific to blood products, where we can say yes or no. And I go through line by line. And if there are any questions that the patient has about what is permissible from a religious standpoint, we actually have a staff member who is literally on call. And we can, and I have called this person before late at night and said, I'm sitting with a patient right now who would like some clarification regarding what the religious principles allow and don't allow. So I'm very fortunate to work in an environment where when there are questions that come up, there's someone who is a Jehovah's Witness and who works for the hospital who can answer these questions for the patient, where I might not be able to answer them because they pertain more to religion. And so I simply go through that sheet, and then, based on what the answers are that the patient furnishes, then, that's how we'll proceed with the surgery. I make it abundantly clear, particularly in cases that, as you said, are high risk, and we're talking about a patient who refuses, PRBCs and platelets and cryo. I just say, if there is a major bleeding event, and the only way that we could save your life would be to give you a transfusion of blood products, is that something you would want? And I just, lay it out in no uncertain terms, recognizing also that this is, for many patients in this situation, is something that it's a conversation that they likely have anticipated if they've not had it before. So I don't get concerned that I would be inducing undue stress by laying it out in plain terms like that. And I just want to make sure that I have a good understanding of what their wishes are. So that tends to be my approach. In the future, if I'm practicing at an institution where I don't have a Jehovah's Witness on call, it make it a little more tricky in terms of the patient being able to answer questions about what the religion allows. But I think I would always like to have a list of every product and have the patient indicate. And I would put that in the chart. And I think it's useful for future reference if the patient comes back in for surgery. Curious to know what your approach is, generally speaking.
I really believe in, again, the autonomy of the individual. That's just how my ethics are framed. So, everyone has the right to refuse treatment. One of those principles of, you can't request treatment that's medically unnecessary, but you can absolutely refuse treatment. I see that there's a lot of value in autonomy like that. And I think where it gets tricky then is, imagine you're uncertain of someone's status for refusal of blood products, but they're next of kin, or you can take whatever steps of distance of that relative saying that they are, but you have no evidence that they are. And what would I do that at the point of giving them blood products to save their life with an unknown situation, or just a hearsay of a relative of some sort? I think that would be incredibly difficult. And this is really one of those real ethical dilemmas. And I think it's one of those things where you'd share the decision. You'd ask your colleagues, you'd maybe even go up straight to the medical director and go, look, your patient's about to die. I need to give blood, and we are not sure of this status, and death is final. Whereas, and then the next one is, the child of a Jehovah's Witness, the family refused blood products for them, but often, children don't always end up in the same religion as their parents. And I think, I can't remember if there was precedence for this, but I get the sense of, please don't hold me to this, but I get the sense that if a child was about to die, you would in Australian law, probably treat them. I say that very cautiously. This is definitely not medical advice of any sort, but merely a podcast of discussion. But these are two of the really tricky scenarios. Do you have anything to add to those two situations besides how painful they'd be?
I'm as far as the pediatric patient who is the child of a Jehovah's Witness. I am inclined. It has admittedly been a while since I have read anything about that specific circumstance, but I'm inclined to say that the precedent is pretty similar in the United States in terms of, this is the kind of situation where I think if there were time, you would get a court order. But assuming we're talking about a life-threatening bleed, then if there weren't time to do that, I believe there are mechanisms in place and legal precedent, to transfuse a patient in that situation. I'll need to brush up on that.
That's right, for the exam. I just wanted to mention as well, I did some work up in Darwin. It's in the Northern Territory of Australia, and far more Indigenous people are treated. So in my time in Melbourne, in metropolitan Melbourne, I didn't treat many Indigenous patients at all, or First Nations people. But in Darwin, I did. And just understanding that consent is very different for them. So, often you'll get the auntie or another relative of the child coming to accompany them, and the child can't really consent because of their age. But it was just a standard thing that the family and the tribe and the group is often very busy doing other things, and there is a nominated individual who is there, able to consent for the patient. So we had a whole session just on one of these aspects: the fact that often the parents aren't immediately in charge of the child, or the next of kin, the way in Western culture it is. And that was really interesting. And again, it's still a bit tricky. I mean, luckily it wasn't anything dire. The operations were low risk, but again, as soon as you're outside of your cultural heritage, or as soon as it's different, it really feels difficult when we're talking about life and death things.
Great. So if I may ask you, we're talking about pediatric patients. One of the questions that come in, full transparency, I'm getting ready to start a pediatrics anesthesiology fellowship in a handful of months. One of the questions that comes up sometimes in the conversations around anesthesia ethics, which I realize are fairly rare conversations, but suppose you have a pediatric patient who does absolutely not want to be operated on and does not want to receive anesthesia, doesn't want anything to do with the hospital, for something that's absolutely not a matter of life or limb. How do you proceed? And I realize, of course, the answer hinges on how old the child is, and you can sort of get into the edge case of what if the child was, if they're 11, are you gonna force a mask on their face? You will. Okay. What about 12? Well, so what's the difference between 11? Well, like, what if they just turn 12? That sort of thing.
12 plus 1 day and 1 minute. And
Right.
Yeah, really, really difficult. I think one of the toughest situations we will hypothetically ever face is, imagine a child who's definitely doesn't feel like they're a child. They're not. They seem in that kind of adolescent period. They definitely don't want the surgery, and the parents definitely do want that surgery. And what are you going to do? Like, are you going to force a mask on them, or force a needle into them, or do a ketamine dart? I think there's a certain point that it feels very, very awkward. I think trusting your gut in that regard, and personally, what I would do is I'd just trust my gut and say, look, this is an elective procedure. There's no harm out of this. Maybe it's a cosmetic thing. Maybe it's totally elective, but it can be decided upon later. And still, there's a good time frame for this. I would err on the side of, if the child vehemently does not want this done, I wouldn't try to force something. I think there's a lot of damage that can be done with that, and also damage between the trust of the child and the parent. But then also the fact that I think the law generally in Australia protects your ability to decide competence, and I think that what we talk about is Gillick's competence. I think that's actually a term that's used probably around the world, because I think it's an Irish family. But anyway, the child wanted contraception. Very Catholic family, didn't really want that. The doctor gave contraception, and it was deemed that the doctor was able to identify or decide upon the competence of the child in that case. And again, there's whole degrees of this. It wasn't the child wanting to have cosmetic surgery that has no medical benefit. This was, the old contraceptive pill or something else. It was not in the realm of, disfigurement of a body. So there's gradations in this as well. So yeah, I think it's incredibly
and I do think it is important to make sure also that we distinguish between capacity and competence. My bioethics professors would be.
Oh, tell me about that. Maybe I'll be
sad if I didn't do that. So, as I understand it, capacity pertains to a specific decision. Capacity to have an inguinal hernia repair done after having gone through the informed, or that as sort of part of the process of informed consent, and everything that's bundled with that, understanding the risks, the benefits, the alternatives, right? Separate from that is the idea of competence, which is a more global ability to make medical decisions. And that is something that, as I understood it, it is decided more from the legal system. So a judge could deem some person to be incompetent to make medical decisions. Whereas, capacity, a patient may have the capacity to make one medical decision and simultaneously not have the capacity to make another medical decision about something that is maybe more complex, and they don't demonstrate that they grasp an understanding of what that is. And I think sometimes there can be confusion about what those words are. And to be honest, it's been a while since I've looked at a definition of both of them. So, I should brush up on that as well. But I think those are important words to distinguish.
Yeah, I definitely didn't appreciate the difference between those. So no, thanks for that. That was actually quite useful.
We should also double check those, but as I recall, that is what the difference was.
I think one of the other questions you wanted to ask was about giving opioids to a pre-op patient in significant pain prior to going through the consent process. Yeah, what are your feelings on that?
Right. So you and I had been chatting a little bit before we got on this call here, and one of the questions that's come up in the literature is about how an anesthesiologist and anesthetist would deal with administering a potentially mind-altering medication to a patient prior to having gone through the anesthesia-informed consent for a surgery. And the situation that, of course, happens, frequently is that a patient comes in from the emergency department, they're in a ton of pain, they need to go back for their, whatever, the ORIF of whatever was broken, and they're requesting pain medication. But what if you make them sedate with the pain medication, right? So, I guess the question is, what would be your feeling on giving an opioid? Maybe not paracetamol.
No. So I think the first thing is, everything in life is mind altering. Not to take it back too far, but to directly answer the question, I know people are receiving endone for pain to get them to a reasonable set of comfort, because pain is mind altering. So I can't imagine a case where someone's in pain and I give them pain relief and they're now making decisions in a worse manner. So I would always give pain relief to a reasonable level. Maybe even if they got more sedated, because the opioids, I'm pretty confident, don't alter the mind in the same way. I'm not giving heroin. I'm not trying to give euphoric agents. I'm just giving an amount of an opioid to get them into a reasonable state. And again, I think the law defends my ability to judge their capacity to then decide if they want to go ahead with things. If you happen to give that 1 in 1,000 person alfentanil and they just go, "Oh, that was the most amazing drug, doctor, give me some more of that, I am in heaven." Like, at that point you go, well, okay, now this feels a bit mind altering. So I think to give a reasonable dose of pain medication, it just doesn't feel like a problem. And I will be well able to judge the capacity of this patient. But even giving midazolam, right? So, I had one of my supervisors back in the day say, midazolam doesn't change the way you make decisions necessarily. It just changes, changes that you may not remember your decision. So, you haven't changed your personality that much. I don't necessarily agree with this. I think.
Yeah, I don't know that, with all due respect to
that one doctor
who I'm assuming was is an excellent position. I don't know that I agree with that notion.
So then this thing of everything affects your mind, I think we were chatting before about how if you say that there's a 90% chance of this surgery being a success, that feels very different to someone saying, look, there's a 10% chance you might die. Or 90% survival, 10% death. If you frame it in the positive or the large or in the positive, people go ahead with that decision. So I think a lot of this conversation is this what this person will do as part of what their natural state or their nature or their normal mental state is, and not trying to alter that with language techniques or neuro-linguistic programming or trying to sell a certain product through any kind of marketing knowledge you have. These are real things that can happen to patients, and the biases that we as clinicians can have if we might have some kind of reward for the service we're giving. So I think that's something to really be careful about, whether it's opioids, drugs, or the words we use.
Agreed. Very well put.
Yeah, good. Hey, so that's been about an hour. That's time flies when you're talking about consent, doesn't it?
Is that right? Wow. Yeah, it's interesting. I wanted to relate a story when I was interviewing for residency, and I had written a couple of papers about ethics and anesthesia, and I'd taken bioethics classes in medical school, and I on more than one occasion encountered an interviewer who said, "Ethics and anesthesia, what ethics are there to talk about?" And I said, "Well, I think we'll have plenty to talk about in the course of the next 15 minutes as we have an interview right now, because I think, at face value, it doesn't seem like there's much, there are many ethical quandaries that are bound in anesthesiology, but I think this was, over the last hour.
But I mean, it's like,
there's really a lot.
Ethics isn't everything. Like, say you go to buy a TV, there's ethics in the way someone will tell you about the product you're going to buy. It's just that anesthesia, unfortunately, is very much life and death in the whole perioperative circumstance. Often patients are absolutely fine. It's very low mortality, and surgery is extremely safe in Australia, I know in the US as well. But at the end of the day, some patients have to deal with these life and death issues, and that's what makes it so difficult. And that's the hardest part of it. Then there's everything else, from the management of pain and nausea, and the implications of having product placement and people sponsoring stuff, and what kind of gifts you receive at work, and it's one of the things. Like I with my channel, I'm never going to take any sponsorship. I just don't want to be ever. Like when we publish something, as soon as you take one thing, just from this functional point of view, not from the ethical point of view, you have to say that you had that grant given by someone. I never want to have to do that. It's just irks me that could ever be a thing. Plus, you don't want to be beholden to anyone when really it's, you're a YouTuber, it's your face on something. That said, if I really like a product, I reckon I'll just say for free that I like using that machine or that medication.
That's a really interesting ethical question, and at the risk of extending our conversation too far, I do take sponsorships on my YouTube channel with certain products, and the prerequisite for me is that it has to be something that I not only believe is helpful, but also can have pretty solid, at a minimum, pretty solid evidence that it's something that's ultimately a benefit to patients in the right circumstances. But I absolutely respect the standpoint that you have regarding it. But my feeling is, if it's something that I really endorse, whether or not anybody is giving me anything for it, then I'm happy to just continue endorsing it. If I'm also, receiving some sort of compensation for that as well.
Look, that actually makes a lot of sense.
But
interesting.
That's
and it really is like it really is a stance on however you want to be in that regard, and what holds well with your own ethics, isn't it? No, that's really interesting. We should definitely have a longer chat about that. That would be fascinating to pick apart at the risk of both of us sounding a bit weird.
No, I think honestly, it gets at sort of a different dimension of being a physician, which is being a physician who also has a presence on a social media platform. And, I think there are many, many more of us now, us being physicians with presence on social media than even just 5 years ago. And the fact of that, I really think, I don't have any numbers to support this, but it just feels like it's been kind of a tidal wave, particularly since COVID. There are so many new issues that get brought into the fold about what appropriate behavior entails. Not that the sponsorship issue wasn't a question, before social media, papers you had mentioned and the like. But I think that question gets a sort of new angle when we're talking about social media.
We definitely have to talk about this in detail.
Yeah, conversation for another time about some of the at the risk of boring people, some of the ethical issues that come up with being a physician on social media.
Yeah, we should definitely have some kind of cage match debate about sponsorship and see where it leads. Anyway, that's all right.
How about why don't we write an article for the Hastings Center report? I'll take one side, you take the other. Yeah.
I would absolutely be up for that. Let's do that.
Yeah, it actually sounds like a lot of fun.
Yeah. Good.
Let's put a twist on it. I argue your side, you argue mine.
Oh God, no. I'm going to say no to that because there can't be any part of me that's ever doing anything. Almost. Anyway, we better end it there. Hey, thank you so much, Max, for coming on ABC Anesthesia podcast and YouTube channel. Please check out his channel. So it's Max Feinstein MD, and check it out on YouTube. And we've gone through so much interesting stuff. Please share this with anyone who might be interested. And thank you again. We'll see everyone next time.
Well, thanks very much. It's been a pleasure.
Now, what's new with ABCs of Anesthesia is that we're forming a whole bunch of very comprehensive courses for every stage of your anesthetic journey, from medical student to procedural skills, from foundations in anesthesia, as well as really important exam lectures and clinical anesthesia courses as well.